Cloning myself tonight.
Rick, have you met Mark Fine before? No. We'll have a formal intro soon, but
yep.
Rick's our, Dr. Lopez is our chair, Mark. He goes by Rick.
Nice to meet you.
Here I am.
Hello, Carrie.
Hello. How are we?
Hello.
Good.
Hello.
How about you?
Doing all right, thank you. It's been quite a week. The spring log jam is breaking. Everything's starting to move. So it's good. It's good. So, and look it's still light out. We're moving. There's the you can see the beautiful trees and light behind Rick. It's so nice. It makes such a difference. Such a difference.
And we're not going to get snow, so that's good too.
Is that you're so definite about that?
Well, as of the forecast tonight, I mean, we could get a snow flurry here and there, but
okay. All right, good. Well, it was supposed to be pouring today, and it wasn't at all. So
my brother-in-law lives in northern New Hampshire. He's going to get several inches.
That's too bad.
You can have it. It's all yours.
That's too bad. How are you, Shuang?
I'm good. How about you, Carrie?
Doing well, thank you.
Everyone's doing well?
Yeah.
Shuang.
Great.
Hi, Jerry.
Hi,
Jerry. Hi, Jerry.
Christine just popped in. Kevin said he was going to be running late, Rick, and that we should start without him.
Okay.
Jean Delio is not going to be here tonight at all, so just a little heads up.
Taking a couple days.
Good for her.
Well deserved.
Yes. Jackie, when are you taking vacation? Good question.
Right now, Jean's not in the office.
Not right now. You can't do it right now, but unless I figure out how to clone myself for real.
Okay.
Hello, Christine. It's Paula.
Hello.
Hi.
Oh,
Hi,
hi,
Paula.
Christine.
Hi, Jerry.
Hello, Carrie.
All right, so let's call the meeting to order. Tonight we're going to, we have sort of two major topics. One is a presentation by Mark Fine, who will be introduced to by Peter shortly, from MAPC. And we'll review the minutes as usual. We'll do some COVID updates. And that's about it. Were there any other agenda items that people wanted to add or to this list? Sounds good.
Rick, I'll probably give a quick update on some civic and recreation permits. Just
Okay.
towards the end.
We'll do that under the COVID thing. And Peter, you didn't get any emails from the public. I don't see any public present, so we'll move on for that. So we're moving right on to agenda item number 4. And just to recap the history here a little bit for probably not so much for the board because we've all lived through it, but for anybody public watching. The board decided late last summer, early fall, that it would be a good idea for us to take stock of how the health division was running. Was it adequately staffed? Did we have the right systems? What should we be doing differently? How do we compare with surrounding communities? And at the time, we even talked about the notion of what we would need to do to be nationally accredited. And so we had a lot of discussions around that. We developed an RFP. We sent that out. We got limited number of responses. And I think we decided at that point to kind of hold off because Peter was now on the scene And we were thinking, well, let's see how this all plays out over the next 2 or 3 months, with Peter there and how it was all going to work with the current staffing. So in the last couple months, what's changed is that we've decided to go ahead and hire a permanent full-time health director. And it seemed like it might be a good idea to do this analysis, ideally with the new director, but I don't think we're necessarily going to have that luxury because it's going to take a while to get someone. And so second best would be to do the analysis so that we have something to work with. It could form the basis of the goals for the new health director. And in terms of what the recommendations and outcomes are. We have Peter here who can help with that whole process. And the other mundane thing is money. It's always about money. We have $20,000 allotted or designated for this fiscal year, which ends June 30th. And so Jean, I know, has been concerned that we think about using that, or there may not be another opportunity. So based on that, we decided to ask Massachusetts, the Metropolitan Area Planning Council to come back and to present to us what they would consider doing for that sum for this purpose. Hi, Kevin. And so that's why Mark is here tonight. And I think the context here is to really hear what MAPC has to say, what they would be interested in doing, what they think they can do to add value to our health division. And then for us to ask questions and have some back and forth. And then I think maybe to have Peter and Mark or whoever from MAPC come back next month with a more detailed plan. And at that point, we would either vote to approve or not to approve to go forward. Meanwhile, we'll be recruiting and we'll see what happens. So that's kind of, I think, where we are right now. Carrie?
Just one, I think, because you did such a good job summarizing the things we wanted to do, and it was kind of a broad list. So the one thing is kind of making sure we're looking at what does the town need to be doing to measure up to meeting the requirements of the Mass General Law, as well as then, national accreditation standards, and, what are the implications for the town with the advent of the SAFE Act. So, yeah, a few different benchmarks.
I think we did include those benchmarks. And we actually did, back in February, had a conversation about revising the RFP.
Yeah.
That had some detail in it.
Yeah.
So I'm going to turn it over to Peter to introduce Mark, and we'll go from there.
Thank you, Mr. Chairman. And Mark doesn't really need much of a introduction. He's well known for a while now. I would say many years, but not as old as I am. I know what it feels like. People say, "Oh, you've been around for many years." But he worked with us as recently as a month or so ago when we were getting prepared to apply for the current grant in public health excellence. I've known him in Danvers for many years during my career there. He was always helpful and willing to come pretty much at the drop of a hat. This guy is incredible. When you ask him for a referral or you ask him for some advice, he really finds time for everybody. He's a thoughtful man, has worked in public health circles and among communities for a lot of years. I spoke with him this week. I think we are seeing eye to eye on many things. We're going to figure that out now in public here, but and there'll be a couple of surprises. I'll let one out of the bag by the name of Sam Wong. And we'll discuss him as it's appropriate when Mark is ready for it. And I don't know, I think I could just turn it over to him. He's certainly capable of running a meeting and giving us all the information we potentially will need to move forward on this. And I hope we can, by the way. Thanks. Mark?
Yeah, thank you. Thank you, Peter. No, very nice to be with you all. I imagine this has been quite a year to be members of a Board of Health and to be in the local public health sector. So I commend all the work and effort you must have been going through this whole time. Yeah, I mean, I did prepare some slides. Peter thought that was a good way to go. So I'm glad to do that. And, through that, I can kind of talk about, who we are, also some of the work we've done that is similar to, the work that I think you're looking for. And, and some of the kind of ways we go about that work, what are the types of things that, usually kind of form the basis of our, kind of scope of work, the approach and processes we proceed with. And then, kind of some of the things we look at as sort of, benchmarks and kind of frameworks to, inform that work. So I'm glad to, share those slides and go for it. And anytime you have any questions, you can feel free to, chime in. I mean, I would say, we were a respondent to the RFP and when it previously had been issued and so had been interested then and remain interested. I did after that, Peter and I connected and, I did say, MAPC, we are, a public agency. We represent 101 cities and towns in Greater Boston. Reading is one of those. And in some, because we're, Reading's a member community, it doesn't necessarily take a formal procurement process to bring us on board. So that is something that Peter and I talked about. So, it's good it's good that, there's still interest in potentially doing this type of work. And I appreciate the opportunity to speak with you tonight. So I'll share the slides and then we can go from there. Yeah, let me know. Is everybody able to see that?
Yes.
Yep.
Great. Well, one sec. Hold on. Let me make sure it's working. It's not letting me scroll forward. Oh, there it is. Well, yeah, so as I said, we can talk about, the kind of scope of work basics for a project like this, some of our process and methods, our experience with public health analysis and especially local public health work. And then, some of the foundational public health services you all mentioned, not only, looking to ensure that the town is meeting, any general law standards, but also potentially national accreditation or even, what the state's been looking at through the SAFE Act. We kind of used a framework looking at foundational public health services, which I think jives with a lot of that. So we can talk about that and then, potentially what moving forward together could entail. So, yeah, I mean, when it comes to the type of, approach we take and what sort of forms the basis of the work we do, I guess, there's some basics really that underpin it all. And we've done a number of reviews of public health departments, in Greater Boston, either in some ways across multiple communities at one time, but also sometimes individual health departments. And, I think the starting point we always, begin our work with is kind of a baseline understanding of, the existing services, the staffing, budgets, and the external relationships. What I mean by that on the external relationships is really understanding like the partnerships that the community and its health department has with external parties, because as we'll I'll talk about later, it isn't just the health department that is responsible for improving public health outcomes in a community. There's many other parties and players that play a role in that, and how to leverage those partnerships is really important. So we also take a look at that. I mean, I think a key thing too is really like, what are the priorities and goals that key parties in the community have for public health? And I mean, I'd start, first off with the Board of Health. What is it? What are the type of issues and, programs and services that you see as priorities? And, we would want to, engage with you on that. That's always good to understand, what are you looking for? From there, I think we kind of move into sort of an analysis phase, where we're identifying some of the challenges and gaps in services and staffing, and in those external networks. And, as part of that, we would do kind of a comparative analysis to peer communities and bring some of the experience we've seen in other communities, to bear and, look at Reading in that light. So that would be sort of the second phase of the work. And then, finally, we usually, try to get to some options and models to consider and then assess kind of like the pros and cons of those. And that's really looking at that, do they address some of the challenges and gaps that, were identified, and do they, get towards some of the priorities and goals that the community has for public health? And through that process, we're able to then make some recommendations. And, they're not just our recommendations. We're not looking to sort of say, here's what you should do. We're not, oftentimes I think the best solutions come from the people who've been working, on these issues for a while now. So, and are involved and engaged in the community on these issues. So we would, shape recommendations that, reflect, the views of key stakeholders and others. So that's kind of the scope of work basics. And that's kind of our way of working. And I think, within the budget you identified, we would be able to do, generally, be able to do all these elements of that work, and produce a product that met all these objectives. So that's on the scope of work. Just when I think about our process and methods, a big piece of that is interviews with key stakeholders, in Reading government to start, but then also, learning from you, like who are the other kind of public health and health players that you think we should engage with, and speaking with them. Obviously we do like a staffing and budget document review. We'd want to look at the numbers and, and I think when we think about the numbers, understand, what are staffing levels, and kind of FTEs, but also what does the kind of workload look like, as far as permits and licenses and, the type of call volumes and other things that the public health department has to respond to. I mean, I would say, like, obviously we're going to have to look both, I think at this year, but really beyond, before COVID intervened, what the health department workload looked like, because obviously I think a lot of things have intervened and, this year wouldn't necessarily tell a full story of kind of what sort of a level set, health department, activities were. So we'd obviously want to look backwards, before COVID hit to understand sort of how it worked at that point. And then kind of see like, what did COVID do to, staffing and also what it, and work volume. And then kind of, to some degree, like, what do we anticipate going forward? Obviously, even though we're hopefully, going to move to a post-COVID, framework at some point, we're not there yet. And it's not clear that it's going to happen, overnight. So I think we'd have to think about that too. And then as part of our process, we would also reach out to peer community health leaders and organizational partners. I know people in the field who would have insights into sort of what we're seeing and what we're, learning about Reading's health department, people that we, worked with and know in the sector. And also in some of the organizational, institutions, whether it's some of the hospitals in the area or, other health partners. And then, we do that options analysis and really try to look at like what can work to achieve, the goals you've identified. So that would be, generally the kind of methods we use to do this work. And, we would make sure like as we move forward, we're not, just taking it all away and are going to come back at the very end with anything. We would be updating, the Board of Health or the parties you want us to update regularly with findings and what we're hearing and learning, throughout the process. So there would be like a regular cadence of engagement, overall, over the whole period. So just to share some of the, sorry, my dog is always yeah, I've gotten used to that in the last year, but still a pain. Yeah, I mean, as far as, our experience with similar work, I could point to, a number of examples. This is by no means exhaustive, but some that I think are, relevant to what, the town had put in its RFP. One, in Salem, we did a health reorganization report. It kind of sounds like in some ways not too dissimilar to the timing that you all were, thinking about, because, it happened during a transition of health, health leadership in Salem, and the mayor there and the Board of Health decided like, hey, it was a good time to think about, where they are, what they'd like to achieve. And, what are some of the issues they'd like, the new director to address. And, one benefit was, fairly early on, they were able to hire a new director. So we did have the benefit of working closely with the new director on that project. It certainly wasn't a necessity, but it definitely was helpful. But in any event, it certainly was able to kind of inform the health director's work going forward and some of the goals that the health director with the Board of Health was able to set for Salem. And I guess when I call it a reorganization report, because they did want to look into, the way the health department was structured vis-a-vis some of the other departments in their city government, like their inspectional services department and, some of the overlaps that, sometimes you find there. So we did that work. It, produced a very good, well-received report that I believe we shared when we actually responded to the RFP, but I could certainly share that again. Actually that had built upon a piece of work we did with, a group of communities on the North Shore, and they had asked us to kind of look at some of the shared health services that they were engaged in and kind of, do an analysis on what they did well together, what could they do together, and how could they kind of strengthen their partnerships and collaboration. And I'd say, a lot of things came from that work, including, most recently, we were able to develop, a number of shared service proposals for the recent, public health excellence grants on the North Shore. So we translated that assessment into some proposals for that region. I know, and Peter had mentioned that there had been a grant that was submitted by Reading on, with Wilmington and Linfield as part of this round as well. So that's good to hear. And, we obviously have experience with shared services, and to the degree that comes into the mix with this project, we would be able to, engage on that subject too. Just touching on a few of these others, like the North Suffolk Public Health Collaborative, that was actually a 3-community public health collaborative with Chelsea, Revere, and Winthrop that we helped form. We actually are the coordinator for that collaborative and have spent a really busy year working with those 3 communities on COVID response, but are actually now kind of working on a number of other issues. We run working groups on mental health. We run working groups with them on kind of housing as a social determinant of health, and also on environmental issues, and especially air quality in that. So in that sense, we've, not only helped them shape sort of what collaboration could look like, but now we're kind of leading on the collaborative work ahead. In Randolph, we did a health needs assessment and a community wellness plan. So that was kind of an interesting piece of work there. And lastly, just on the Metro West Prevention Partnership, we did a piece of work with a number of communities in Metro West, Framingham as the lead. And they looked at sort of, a range of issues from kind of indoor, kind of housing complaints and kind of housing issues, kind of smoke-free housing and tobacco control. And we sort of did an assessment with them on how those programs were working and where they could improve. So, and that's actually, one of the instances where we worked closely with Sam Wong, who was the Hudson Public Health Director and then became the Framingham Public Health Director. So, if to the degree we talk about Sam Wong later, glad to share we have a very strong relationship with Sam and worked on a number of things with him over the years. So, just moving forward, just to say kind of who our team is, so there you see me dressed in better than I am now. And, I'm the Director of Municipal Collaboration, or a Municipal Collaboration Department. A colleague of mine, Brian Luther, is our Municipal Services Specialist. We form, kind of one half of the team, but our public health team and our Director, Barry Keppard, and our public health planner, Elaine Zhang, are sort of the other piece of this. And the reason, our team kind of has come together because, obviously it's great to have public health expertise and people who understand the issues and the science to a degree. But, there's also a level to which, we're really talking about partnership working and collaboration and the kind of inner workings of municipal government. And that's kind of where, my and Brian's expertise comes from. So, we've really, as a foursome, worked on a range of these projects together, and it's really been a fruitful partnership across our 2 teams. And we would definitely bring that here too. So that's who we are. Yeah, I mentioned foundational public health services, and I guess it kind of jives with some of what you were saying, like I said, around, what type of standards and what type of, goals you're looking to achieve, for the health department. And, I mean, this is whether you're familiar with kind of the term or not. I mean, it basically, was one way of kind of looking at, public health services and kind of what are those areas that, public health services should really cover, not only from kind of an issue and programmatic, vein, which is, around, everything from communicable disease control, which we're obviously, fairly familiar with these days, chronic disease and injury prevention, but over even just to like, how do people access clinical care? Now, if you think about what do public health departments, in Massachusetts really do, I'd say generally, the focus is really on those first three, like communicable disease, chronic disease, and injury prevention to some degree, but not always. A lot of health departments really don't have the capacity to do that. But then environmental public health issues is very much, in the frame. But, these are, and I guess when you think about, what are the programs, but then also sort of like, what are the, capabilities you'd want, a health department to have, that's kind of the kind of bottom, group of points, whether it's, assessment capability and emergency preparedness and response capability, which, whether communities had it or not, they've had to develop and had to, staff, sufficiently in the last year, obviously, but also around communications and policy development and partnership development, and even just some of the business competencies. Like those are the type of things that, in its ideal sense, like a health department would have. But I guess, one thing, that's true is, we have a fragmented healthcare system in the United States, obviously, and, the provision of comprehensive public health services, often doesn't just rely on local and state health, health agencies. It often is hospitals or community health centers or long-term care or social service agencies that do a lot of the things that, in some cases, people would see as kind of public health. And I think it's really unrealistic, given where we are, to expect, an individual city or town to be able to do all this on their own. But I think the key thing is, when you think about this, like how does a community then, lever those partnerships to bring in other parties to help, support its residents, to achieve, the kind of, public health goals it would like. It's not always just about, building up, internal capacity. It's about leveraging those relationships. And I think, when you think about like who delivers what, obviously, local government, like I said, is very much on the environmental public health and the kind of regulatory elements. Obviously, the communicable disease pieces have been really big, but when you think about who plays a big role in things like clinical care, I mean, obviously the state has a major regulatory function, and the federal government too. And I mean, often they house a lot of the health information and, and even public health data, as we've seen, during the COVID crisis, Maven and the systems they administer, which, your staff and colleagues all use, something that, we rely on the state and, to maintain. And, and that's now true with like the vaccination systems and everything that we've, found there. So this is, sometimes when we think about, public health, we use this framework to just consider sort of, what are the range of possibilities and how do you get there across these different domains? So yeah, I'll stop there. I just, I had some concluding thoughts, but I mean, just to give you, a chance to ask any questions, and kind of chime in with anything that I said, and, see if you want to, poke me on any of those matters. I'll stop sharing for now and come back to the real world. But thanks for the opportunity.
Thank you, Mark. That was very helpful. So questions, comments? Carrie?
If anybody else wants to go first.
No.
Okay.
That's fine.
Thanks, Mark. It's nice to meet you. I think we may have been in a couple meetings together, but it's nice to meet you individually. I'm interested in all that you presented. I was interested that you talked about the foundational public health services. I'm curious how how you, I mean, that's a key component of the SAFE Act. That's the basis of the Special Commission report. And I'm glad to see that you're incorporating that. I'm curious, you didn't really talk much about the SAFE Act. Is that something that you anticipate incorporating in this work?
Yeah, we very much would. I mean, we were pretty involved. Like my colleague Barry Keppert, our director of public health, who sadly couldn't join tonight, but I would have loved to have him. But I mean, he'd be very involved in this project. Like he was part of the, the kind of, as the SAFE Act was coming together, he was part of a lot of those early deliberations and kind of shaping a lot of the standards. So we would definitely use that as a guidepost to think about the services and programs that Reading's able to offer.
Good, yeah.
And kind of a touchstone to, consider sort of where is the town sort of meeting some of those standards and where might that not be the case.
Right.
So definitely we would. And, we've been, pretty involved, with, it was SAFE 1.0 and that act passed, and now there's SAFE 2.0 and,
which hopefully will pass.
Which hopefully will pass too, and very supportive of that. And, we're pretty active with the Coalition for Local Public Health, which obviously includes a lot of, MHAB, MHOA, and the other partnership groups. So Barry participates in, regular meetings with that group. So we would, I guess the good thing is we do have a lot of those contacts and contacts to kind of, share what we're learning and test some of what we're learning in Reading with, some of those parties. So definitely, no, it's a very good point. We definitely use that as a framework.
And that's a nice segue, thanks, into my next question, because and I should disclose, so I am the program manager for the local Public Health Institute of Massachusetts, which is housed at Boston University School of Public Health.
Sure.
I was part of the regionalization discussions back in the early 2000s, led by my former boss, Harold Cox. My advisory committee is the Coalition for Local Public Health. I sit on the board for the Massachusetts Environmental Health Association. Yeah. I know Barry, we've been in meetings together. So one of the reasons that I especially was pushing for this report and this audit is what I call it, is that, public health is not subjective. And I want to kind of touch on something you were talking about early on about sort of asking what the community wants in public health, because, there's an aspect of it that is, what are you thinking about? But that's part of the reason that there is a SAFE Act, that there was a SAFE Act and there was the special commission, because in every community, public health is delivered differently. And the quality of your health and the quality of the services that you receive vary by your zip code. So, I just kind of want to check in on the, how are you anticipating addressing the objective requirements that exist in the code and in the general law to make sure the community is meeting those. And kind of how do you choose your communities, and how do you incorporate what's meaningful in all these different communities that all do it differently. I've worked all over the state. They are 100% different, So I'm just curious, how do you incorporate that? How do you take that into account?
No, it's a very good question. I mean, and obviously, to some degree, I think we do want to hear priorities and understand where the community's at on things, because I think, not all communities are trying to get to the same place or are able to get to the same place in a step or two. And I think, understanding where they are and how far they think, and where they want to go and what they can actually afford to do, to some degree shapes like, the recommendations. I mean, we're certainly not to be here to tell communities, here's all the ways you're failing, even if in some cases, maybe you would call it such. But I think, certainly if the Board of Health, if it's the aim of where you all to really meet those standards, we are willing to, use those as a way to, make our assessments and analysis. And I think, and to call that out and say, where we think, there's gaps in trying to achieve that standard. I think we're more than willing to do. I guess maybe, some of it's just how I've learned over the years that usually when we've gone into a variety of projects, and public health in particular, when we come in with anything that seems as like a heavy hand or kind of we know better than you, it hasn't really worked. So, I mean, maybe I was being careful, but if there's an interest in sort of, that type of, kind of, meeting those standards, I mean, we can certainly, work with you to see where the community is at,
Yeah.
comparable. And I think you asked kind of about the pair communities and which ones we choose, but obviously there's kind of demographic comparisons. We have, MAPC has a ton of data. I think we had provided, with our RFP response, a number of kind of, a list of pair communities that we thought sort of both in kind of population, maybe levels of kind of, a demographic profile kind of fit the bill. We would, work with you to kind of tailor if that works, including based on what you know about their health, departments. Because like you said, I mean, one thing that's true is you could have two communities with a lot of similar characteristics. That doesn't mean they're going to do health the same way.
Yeah.
And it's not always clear why. It's history and legacy and interests, and that'll shape a lot of it. But yeah, I mean, we can certainly kind of present that, tailor that, in a way that you feel makes sense, and share why we think these are the communities we would engage and talk to. But some of it would be, I think, also talking to some of the public health leaders we think can really add value, because there's a range of capabilities and capacities around local public health departments, and we've gotten used to and know a fair amount of folks that I think we would definitely want to be like, hey, what do you think about this, or where how does this compare to some of what you've seen? And so even in some cases, it might not always be like a peer in a perfect sort of profile demographically, but it might be because this is an individual we really think we can they would have insightful views on sort of what we're trying to do here. And I mean, I think like Sam Wong, like we've talked about, like he's somebody we kind of use in that way now. We were really, it was unfortunate what happened in Framingham, because we were working quite closely with on a project down there around kind of shared public health nursing, and that kind of definitely put a spammer in the works. But we've been talking to Sam a lot over the last few months too. So like he's somebody like, even if you hadn't mentioned it, I'm sure we would have been reaching out to Sam to get his views as well.
Yeah, Sam's an expert. He's a public health expert, and it made me quite pleased to see in the notes that Sam was going to be able to be engaged in this, because you need the public health expertise. Public health, and I'll take your point that the different communities do it differently for history. And again, I'll go back to that's why there's a SAFE Act, and that's why there are now workforce standards that are going to be implemented, because it's not subjective. The laws are the laws. What ought to be enforced and what ought to be in place are what exist. And that's a to be able to work with someone such as Sam, who's a friend, not just a colleague, but a good friend, is, I think, an excellent thing that would be useful for Reading. So, and there was one thing. I can't find it. I can't find, okay. Yeah, I'm sorry to hear that the Framingham thing hasn't worked well. That was Framingham's loss. It was a real shame. It was a real shame. All I know, I wanted to say that I can't speak for anybody else but myself to say that I believe that our standards ought to be, what is the law? What is it that the community ought to be doing? What are we held to as members of a board of health? And, kind of where do we stand on that? Understanding that not all of it can be achieved. And that's part of the reason for regionalization and shared services, is that there are things that regions do, there are things that the state do. That's the way the 10 essential services were delivered, and that's the way foundational services should be delivered. So, yeah, I think that's right.
I think,
go ahead, sorry.
It's in some ways it's sort of like taking care of a patient, where there's evidence-based way you take care of what you're supposed to do, and then the patient comes with all these perspectives. And,
yes.
If you go in like a bull in a china closet and say, this is the way it has to be, you won't get the outcomes you want. So
right.
I think you're absolutely right, Carrie. There are objective evidence-based standards that we need to follow, but querying the community and perspectives can help move in that direction.
Absolutely, yes, it's a both. I didn't mean it to be a not that. Yes,
Right,
it's a
right.
both and. Yes, yes.
Mark, I was wondering, I think in the original proposal, I think I saw like a 4-month timeline. Is that what you're thinking here in terms of this piece of work?
I think
It
that's
just
probably right.
slowed down a little bit, from.
Yeah, I mean, I think that's probably right. I mean, that dovetails with some of the work we've done in on kind of similar projects. Yeah, so I mean, I think that's probably right. I mean, obviously, when it kicks off, sort of might impact that and sort of launch. But I mean, I think that's generally the window we'd be working, to on a project like this, kind of over a quarter. And some of that's maybe just to some degree, like what type of cadence of engagement does the board want or other parties want? I mean, that might impact things. But I mean, I know like in Salem, for instance, the mayor and Board of Health had convened a task force and they met regularly. And, we to some degree had, some of the cadence of work was kind of dictated by what they could do and when they could meet. So that might impact things. But as far as, we're willing to kind of like, think about that with you all and, who you want engaged, who you want kind of, to play sort of a regular role, when the board would like to have updates, we're glad to, to work, flexibly in that way.
Yeah, I mean, I think it would be really important for the board to have sort of regular check-ins, so that when we get to the final product, we're not surprised, disappointed, shocked, or, we kind of have input and feedback along the way will be really important. Along the lines of engagement, how would you see Sam Wong, Dr. Wong, who I don't know, I Googled him, so I have some background, but how would you see him engaged in this process if you were to have him be part of it? How would that work?
Yeah, like obviously, like we haven't actually talked to Sam about this. I mean, I only heard from Peter about, his potential engagement the other day. So I mean, it's, we'd have to kind of figure out like sort of what level of engagement he'd like. But I think in my head, it sort of seemed like, he'd be a subject matter expert and kind of a trusted advisor. And we would, in some ways we would be, vetting, our thoughts and materials through him, in a sense, before they got to you all. We'd be kind of maybe asking him for advice on sort of, what are the, make sure that the things we're looking at, the people we're talking to looks right, kind of guiding our process and approach, making sure that he has input in that, that we then, as we're collecting findings and information and data and pulling that together to kind of tell, and thinking about like, what is it telling us that, he can provide us insights on, what we think we're seeing and kind of, we could, test that with him. I think we kind of use him as a regular kind of touchstone as we move through the phases of the work. And even, as we're thinking about like peer communities and, and kind of even public health and leaders that we should be talking to, I would love to hear from him. I mean, he seems to know everybody in the sector, all his peers and colleagues. So we would want to make sure that he's, giving us some guidance on that too. And then obviously when it comes to like, the options and recommendations, we would want his kind of close advice on all that. So that's kind of what we're thinking. But obviously, we do have to talk to Sam.
Sure.
Within the budget constraints, we'd have to make sure something reasonable can, because we'd want to make sure he's obviously remunerated for his time and effort. And we'd have to just see like what can, within that budget, what could work. There is the possibility sometimes we're able to also devote some of our own technical assistance funds, that the agency has to kind of supplement a project. So I can't promise we can do that here, but I might be pushing for that just so we, can put the time and effort in that we think we need. But yeah, that was my thought, on that, but I'm glad to hear any views.
Any other questions, Jerry, Kevin, Paula?
About the timeline too. That was all.
Mhm.
Yeah, I just had one. You did mention this, and hi, Mark. Nice to meet you, by the way. You did mention COVID versus kind of what used to be called normal times. We won't call them those probably ever again. But you know, how do you kind of approach this? It's a tough thing to do because we're really looking at you to assess, you know, who we are. I guess more post or pre, but certainly during now and moving forward, what that's going to look like. You know, it's going to be kind of a little bit of a changing atmosphere. How it seems like a little bit of a tough data point for you to hit. You know, here's what you used to be, here's what you are right now, and here are the lapses currently. You know, what about the lapses moving forward? You know, that'd be the more interesting key point.
That definitely seems to be, I mean, on a lot of people's minds, because I think, I mean, as you guys are probably seeing, like health departments have basically had to prioritize COVID over almost everything. And even getting back to sort of like all the basic, you know, regulatory work has been really hard. And frankly, I mean, from some of the health directors we've been talking to, it seems like, you know, without like additional support and resource, they're fearing they're not going to be able to meet some of those, you know, basic standards. I mean, you know, in the near term, I mean, hopefully as things settle, that might change. But,
Right.
But I mean, it's a real big stress point. I mean, maybe we would in some ways think about that. Like, what is it? Not only like, what do you know, what is like an ideal public health department for Reading look like? But, you know, I think it might be like, how do you kind of, you know, move through the times we expect to be, you know, we're going to be in to kind of get there. So it isn't just like, all right, you know, do this and expect it's going to happen. It would be like, you know, you're going to be looking at, you know, a different, you know, landscape in the fall of next year and in the winter and spring of next year. And what could kind of maybe a ramp up look like to try to get there? Because, you know, because COVID in some degree is going to be with us over time, and the responsibilities that entails for public health departments are going to be there still, you know, including, I think, like some of the state resource that's been really helpful, like the community tracing collaborative. It's unclear, you know, that might not be stood up for a while. And so some of that, you know, responsibility might fall, you know, back on local health. So I think we'd have to think about the recommendations and options in light of that, like, and maybe think about them in kind of a nearer and longer term framework,
Mhm.
you know, to address that, if that makes sense. But yeah,
Yeah,
obviously
that does actually. And that's actually a great way to think about it too. You know, you have all these different help that we have right now certainly come from the state, which is going to go away. So it's a great way of perspective to look at it. Okay, let's pretend it all goes away. How do you guys handle it now?
Right.
That's kind of that's a good point.
yeah, I mean,
interesting way to look at it.
I worry about what the fall looks like, just because, you know, I imagine there'll still be some clusters and things happening, and, you know, but, you know, schools hopefully are, you know, back full time, and, you know, people are kind of working in a more normal way, but, you know, maybe some of that resource that we can rely on at the state level is not there anymore. So what does that mean for our local health and just getting the day job done, you know, the things that, you know, local health has been meant to do, you know, historically, and, you know, has been really stressed in its ability to do it over the last year. I mean, one thing I know, like I know MHOA, I think they're doing like a webinar on that, you know, coming up maybe in June. I think I heard that. And so we were gonna, you know, I mean, one thing we've also been, just so you know, like we're the sponsoring organization for the Health and Medical Coordinating Coalition. So these are, you know, they're kind of multidisciplinary emergency preparedness coalitions. And we do Region 3, which Reading is within. You know, and then we were also the affiliate for the public health kind of emergency funding that came to, you know, all the towns and cities throughout this crisis. So Reading being one of them, you know, we've worked with Peter and Jean and co as that funding has come out. So, I mean, in that role, we have been engaging in kind of these questions with the broader, you know, kind of region. And I think we're going to continue to do that. So that hopefully can inform some of what, you know, we do here. It won't be like Reading in sort of a vacuum. You know, hey, how do you get it done? Because I think this is a question for sort of every, you know, a lot of local health departments right now. And I think, you know, it might also, I think, you know, what happens with the shared service grants and sort of how that plays out, because maybe
Yeah.
that's, when you think about building back some of that capacity and getting to it, the shared service, supports might be really important. And finally, the state's put some real money behind that in a way it never had before. So these are, grants that can really fund actually like full-time staff. And, that might be able to make a difference. So I mean, how that resource gets deployed, how quickly it can get deployed. It seems like everybody's looking for the same thing. So I sometimes I'm like, wow, there's going to be a lot of hiring going on, but hopefully
Yes.
there's enough people to be hired. But I think that'll be interesting too. And I think also, how, the sustainability of that funding is really key, because, obviously, a one-year grant doesn't help a lot. You need it
Right.
to be sustainable over time to make a difference. I think that's the aim. I'm feeling like, in some ways, as terrible as COVID was, it's finally focusing people on what public health needs are. And, maybe we can seize that opportunity to really build, the capacity that's necessary. So that's the hope.
And I know you said this earlier, but you do feel like you have that capacity to talk to the other two communities, Linfield, Wilmington, because it would be interesting to see out of the three, who does what well, what's going to be the most effective use
Right.
of the services coming out of each department. So would there be room in this budget, so to speak? I know that's
Well, we might have to think
that's always the
creatively.
add-on.
We might have to think creatively, but we're pretty good at
Okay.
that. I mean, I think, I think it fits in the remit. I think it has to be part of the conversation. And we definitely, we know the health officials and other public officials in those communities pretty well. So, like that could be part. I mean, they are, I think, immediate peers in many ways. And, even if the shared service grant hadn't proceeded, I think we'd want to be talking to them anyway. So hopefully it does. And then we can, that will help.
Let's hope that it does. Exactly.
That's right.
Okay. That's right. Thank you so much, Mark. That's all I have.
Yep.
So I think that what we probably should do is ask Mark and Peter to come up with a more detail. I think the high level, Mark, that you presented is perfectly appropriate at this point, and we get a better sense of MAPC. But ask you both to come back at a meeting in May to with the detail of how you would approach it. Maybe by that time we might know if we got that grant or not. But specifically,
I think you will. So that could be good knowledge.
I'm hearing there weren't too many grant applications, so maybe by default we will. So hopefully, and so come back, with a little bit with more detail. How Dr. Wong would be involved, how we would be, engaged specifically. I think a lot of it is in the original proposal you did last November, but that would just be scoping it down based on today's conversation and the fact that we're really focused on, what we can do here in Reading better in the future. And then we can kind of go ahead and take a vote on that at that point. Does that sound right to everybody?
Yeah,
Yes.
absolutely.
Yes.
Okay.
I mean,
That sounds
the
good.
best thing I can do right now is keep my mouth shut because everything is going where it should. That's not what I'm famous for. And so I just want to make sure the conversation takes into consideration, this point here. I mean, we're always looking for ways to measure, the outcomes. And in years past, we used to count on health status indicators that the Department of Public Health kept for all the communities and the regions. And we would look at them and see, oh, this was spiking. So how can we intervene and check in 3 years that this would be, that what we did actually affected change? I'm not sure that's going to be, possible these days. And I really like the way Kevin thinks, and we've had plenty of conversations about this, but he brought us futuristically. And we're at what I think is a watershed event where things are coming together so rapidly, it's almost, mind-boggling. We have this opportunity to study what we do. There's a grant coming out, and day by day it looks better and better. I'll fall out of my chair if we do get it, but it's possible. In any case, we're still looking at, working collaboratively between the communities we've talked about. And So then there's the reorganization piece that the town is committed to, which includes, my interim director means that it's temporary. So we're going to be getting a new person. Now, if it's okay with you folks, if we can combine everything that Mark has said, Kerry has pitched in with, and Kevin, and kind of include what the future could entail in terms of those things. How do we do some more regionalizing with a new person and potentially with some grant money? I'd like to be able to come back to you folks, and I will be giving you updates, through reports before we meet on the 23rd of May. But working with mine and Mark and finding out Sam a little bit more, we're gonna have to talk, and keep everybody happy about Sam's role in this thing. We don't want to underutilize him. So I wanted to put in that piece just before we close out here, so that when we do come back with some ideas, was like, wait a minute, that wasn't discussed on April 15th. Well, I think we do need to look to the future, as Kevin suggested, and find out how this new director and this whole regional shift is gonna look and if we get a grant, and even if we don't. I guess that's all I have for now. I could get caught in the record jacket somehow. Was I not clear?
We get the gist. We
We got it.
It sounds good. Sounds right on.
Right. So thank you, Mark, for joining us tonight. I appreciate it, and we look forward to talking with you again.
Yeah, thank you all. Good night. And,
Good night.
done,
Nice to
Mark.
meet
Nice
you.
meeting you.
Thank you.
Take care.
bye now.
Take care of that dog.
Yeah.
Yeah, I'm trying, man. It's been a year of cohabitating all the time with the dog. So yeah, I'm not so great at it, I guess. But anyway, good luck all. We'll talk.
We'll be
Thank
in
you.
touch, Mark.
Thank you.
Good
Thanks so
job.
much.
Thanks all.
So I have a question
Sure.
in light of this. Having missed the last meeting too, so I couldn't really voice it before. We have been talking about reorganizing as a board and expanding the board. With the inclusion, if we go with Wilmington and Lingfield,
Mhm.
would those be our two board members? Is that a possibility? No,
No,
they'd have their own separate board.
they have their own boards. This
Okay,
is
just clarify.
municipality stays as municipality. Yeah.
Okay.
Yep.
Thank you.
And we can't add to the board unless they change the bylaws and
Right.
as much as we want them to.
Yes.
So it's even more than that, Kerry. It's the charter,
Oh, right. That's right.
which
Right. I knew
which
that.
requires a 2/3 vote of town meeting.
I knew that.
Yeah.
I blocked it out because it was, yes, thank you, Kevin.
And actually, I haven't heard much on that front
Me
lately, as
either.
far as when that's going to be going before town meeting. It was an instructional motion made. I don't know where it's at right now.
Right.
Instructional motions, just for everybody who's listening, who hasn't heard that before, is a motion put before our select board, but technically they don't have to act on it. I think they certainly do in this case, which is the good news, but sometimes they get tabled for more pressing issues at hand.
Right.
Sounds to me, Paula, just on your point that we talked about a 3 municipality health director might be an exciting challenge for someone. It could also be an incredible headache to have 3 bosses. Because he or she would be reporting to
True.
3 different boards.
But it's not unprecedented.
No.
Not unprecedented in this town.
No, not at all.
It's not a model that has gotten a lot of success or traction. It's tricky. I mean, it depends on the communities.
Yeah, it wasn't here before.
Yep.
Interesting.
But I think it also depends upon the right person for the right job, as in any situation.
Exactly.
Yep.
All right, so moving right along. Minutes from the April 1st meeting. Any revisions, comments, suggestions?
Not for me.
I didn't have any.
Carrie, did you have
One
something?
change. the closing date for the photograph thing is June 4th, actually. So
Do you have that, Jackie?
Poor Jackie is saying, I'm sorry. Yes. I know they made a nice, generous, long time frame, which I thought was great. So, and I still haven't found my photos to send in yet, but I'm going to, and I hope other people might too, because I think these kinds of reflective and resilient
Yeah.
projects are great and really an important part of.
It's been a year, yeah.
Been a long year.
Yeah.
So motion to approve the minutes.
Second,
Second, roll call.
Do
Karen.
I vote or does Kevin or someone else?
I wasn't elevated, so you're voting.
Okay,
But you'd have to abstain, I think, Paula, because you weren't there,
okay.
right? And but
Did you watch it back at all, Paula?
I didn't watch it. I read the minutes though.
Yeah, I
Right.
mean,
It's fine. You got a quorum. Go for it.
yeah, probably abstaining is not a.
Yeah, I'll abstain.
Carrie, yay.
yes.
Rick, yes. Okay.
Thank you, and nice job, Jackie, getting minutes approved.
Yes,
Thank you.
thank you.
He's great.
She's so good.
Yep.
We love you, Jackie.
Yes, we do. We're,
Especially-
oh,
Okay, so getting on to our usual COVID updates. Christine's on the phone. Christine, do you have the case counts and so forth?
Yes, I do have the case count. Do you think if there's time, it's possible I ask a quick question
Sure.
about the MAPC?
Yes.
I guess one of the things from being one of the public health nurses over this past year is that I did get a chance to learn that Reading is, although some similarities, is very different of a community than some of the other communities, some of the surrounding towns. And I mean, that makes sense. Every community is different and has different needs. One of the difficulties I've had in collaborating with other towns was not so much that the communities were more than willing to help and the public health nurses were wonderful, but some of their resources, like I'll give an example, if they live in a town where a hospital happens to be located, they had, access to maybe more testing or availability for the hospital to work with them in like some community testing, or where I found, I don't know if that makes any sense, but I'm just wondering if there is anything that, I could be doing different. I've certainly tried to build relations with other public health nurses and feel like I have, and I attend a meeting, but that's all. Just any suggestions, and if will the MAPC make these recommendations and sort of help bridge that gap with other communities, or how to will they make suggestions on how to do that?
You make an
That's part
excellent,
of their role.
you make an excellent point that, all the communities are different. They're not cookie cutters. And there's going to, and Peter can certainly convey this in your conversations with Mark, that there will be different aspects to different communities in terms of the resources they have in public health based on what's in their community. And so it can't be just simple blind ratios and staffing numbers and so forth. You have to take into consideration the size of the community, the specific differences. And so I think that has to be part of it. I would not expect them to come back and say, just because the staffing is such and such, or the systems are such and such, they have to look at the other communities, but then there's a judgment involved. And like if there's a hospital or a community health center that's very active, that can really help a community. We don't have a community health center. We don't have a hospital. And so it's a good point.
Yep.
Could I just pitch in for 1 second, Christine? Partnerships was a big piece of his presentation, and trying to
Yeah.
identify places where we could partner should be part of the.
Mm.
Yep.
That's great. Oh, thank you. Okay, so COVID case count, the total cases right now are year to date 1,838. Our active list at the present time is 68. Deceased 49, transferred 10, and recovered 1,697. A couple of other communicable diseases. I ran a report year to date that actually just trickled in over the past couple of weeks. 2 cases of influenza. Hepatitis B, there was 1 acute. Hepatitis C, there was 1 acute and 2 chronic. And Lyme, there was 2. Salmonella, that was from previous, at the very beginning of the year, but I just included it in because I put year to date. And it was from a child and mother who had traveled over to India. And that was, we determined that was where it was symptom onset. And I had a chance to speak with Mary Juliana up at the Reading Public Schools. The nurses up there have been extremely busy. She was able to let me know that 229 high school students have received at least 1 vaccine, which is very exciting. And
Wow, that's great.
yes, yeah.
Yeah.
Wow.
Yep. And they're very busy with pooled testing, but that's been going really well because they've been able to identify and sort of put people in, quarantine and have the rest of contacts tested pretty timely. So she believes that's going extremely well. And she did mention that DESE has agreed to continue financial support of that through the summer. And right now, I know that they're about getting ready to go on April vacation, and we know it's hard to predict, if cases are going to go up, a week or 2 after they return. But, hopefully with the continuation of pooled testing, we'll be able to identify quicker and, begin contact tracing sooner.
Christina, the 229 students, did you say that was all high school students?
Yes, I believe they were mostly seniors.
Right, they would have to be older than 16.
Over 6, yes.
How many, does anyone know how many high school students there are? What the average graduating class is in terms of numbers?
Around like 300 or so.
That's
Isn't
what
it?
I
Like
thought,
280 to
about
320, somewhere in that
Something
range
like that.
Okay.
Yep.
per
Okay.
class.
Okay, so that's a lot. then.
It is.
Yeah.
Yeah, that's nearly an entire class, right? That's
Right.
great.
Christine, I understand that although the pool testing is mandatory for anybody in the sports, and that seems to be where most of the infections are coming from, but that I read somewhere that they're a little disappointed in the number of people that are signing up for the pool testing.
Yes, and I'm glad you just mentioned that. So I did, in speaking with Mary today, I did ask, I said, has the statistic changed? Are more parents opting in to this? And she had said, basically, no, it's still about the same, it's 60%. But then when you do look at some surrounding, if you compare to some of our neighbors, it's higher than, some of the other towns. So it is about 60%.
And it seems to be mostly from the sports, I guess, and that's mandatory for them. So at least that base is covered.
Yes.
Of the 68 cases, roughly. How many of those are related to school in terms of either staff or
Mhm.
students?
Yep, sure. I'm just gonna take a minute to look through my papers right now. I would have to say, school-wise, the statistic is not very high. I would say out of the 68, I'm just gonna take a quick look, hold on. Approximately 18 are school. There are a lot of household contacts and after-school gatherings that seem to be the main. I wouldn't even say sports is at the top of the list. I would say it's definitely up there, but it's more household after school, permitting kids to hang out or get together, unrelated to a sport or school transmission.
Okay.
And do you have any sense if the variants are showing their ugly heads with any great number?
No. So I was notified by Dr. Katie Brown a couple of weeks ago of the UK variant. There was one case identified in Reading and was on a Maven DPH call last Tuesday, and Dr. Brown was able to present then as well, which was really great because she did go over the statistics, and Massachusetts is pretty high up there on the number of variants. And I can actually forward that. I'm not sure. I don't believe I can do it right now, but Massachusetts does have a pretty significant amount of variants right now compared to other states. And she just went over, what to look for, how to identify it in the electronic lab reporting. And, just we're gathering data on, are there any differences in symptoms with the particular variants, more so in one over the other. So we're going to be keeping an eye on that.
Thank you.
Mhm.
Okay, great. Thank you, Christine.
You're welcome.
Shuang, did you have any updates on the vaccination status? Or?
Yes, I do have some updates for vaccination and
No.
okay. So vaccine clinic updates.
You have to speak up a little, Shuang.
Oh, sure. Yeah, let me know if my voice is not. I will raise it up. So today I'm gonna talk about the COVID vaccine clinics, vaccine order and the delivery, and some information regarding the Johnson & Johnson vaccine. So as of today, we have there are 164 individuals in phase 1 fully vaccinated. 389 individuals got their first dose in our vaccine clinics, and 153 people in phase 2 were fully vaccinated. So in total, we administered 552 first dose and 317 second dose. So we total administered 869 doses, and they are all Moderna vaccines. 76% were mainly administered at the regular clinics at Pleasant Street Senior Center and one clinic at Reading Memorial High School Field House. 8% were used for homebound individuals. 9% were given at Frank Tanner and Seneca Lane affordable senior housing on March 23 for their first dose clinics, and they will receive their second dose next Tuesday. The access links for online appointments were sent to those individuals via PerkMod, and a few of them have already made their appointments. And the other 7% were given for Council on Aging program. So far, including the homebound vaccination, we had 18 vaccine clinics in Reading. Vaccine order and delivery updates. So, well, it's interestingly because this time the states deliver our Johnson & Johnson vaccine to Bedford. So on April 5th, I picked up 70 single-dose Johnson & Johnson vaccine from Bedford. These vaccines were planned for homebound vaccine delivery this Tuesday and today. However, as you may know, CDC and FDA recommend pause of Johnson & Johnson vaccine on early Tuesday morning because of the blood clot concerns. So we canceled both events. And thanks, Christine, so much for helping the cancellation of these events. And I will share you more information about the Johnson & Johnson vaccine in my next slide. And in addition to the Johnson & Johnson vaccine, we also received 200 doses Moderna vaccine this Tuesday. They will be used for the second dose clinics for affordable senior housing, Council on Aging plan, and the Reading residents in the coming 2 weeks. In order to complete the second dose for 89 Reading residents on April 23, which is next Friday, we need 33 more doses. So currently, I am still on the conversation with the state regarding the vaccine order. And this morning, I received their response and saying that they are working on getting us more doses for second dose clinic next Friday. And actually, the state has mentioned multiple times that they will not provide second dose clinic, but Reading are do our best to get the second dose for our residents. And by the way, after finish all the first dose clinics for affordable housing and the Council on Aging plan in Reading, we have 60 doses Moderna vaccine left. And we tried best to get the people in because these vaccines are exclusively for the senior program, and we cannot get use this vaccine for other people. So since we could not find more people to get the vaccine, we contact with the state and they guide us to transfer them to Amigo company in Attleboro in Massachusetts last Thursday. Johnson & Johnson vaccine updates. So, because of the 6 cases with rare serious adverse events after receiving Johnson & Johnson vaccine, CDC recommends pause of the JJ vaccine, and mass officials instruct vaccination sites to stop admin of JJ vaccine early Tuesday morning. So our response are immediately cancel all homebound events, store all the JJ vaccine and supplies and mark them as do not use, waiting guidance according to the state. Immediately contact state for replacement. We ask for 70 doses Moderna vaccine to replace Johnson & Johnson vaccine for homebound. However, the states, at this time point, the state is not replacing any of the JJ vaccine and is waiting for more information from the CDC and FDA. So, thank you. Do you have any questions?
Shuang, I seem to remember that we had immunized, this number sticks in my head, at 35 homebound patients.
Yes, so far we vaccinated 35 homebound patients.
35. And so when you say that we're looking for additional Moderna, is this for second doses or is this for some additional homebound patients?
No, homebound patients are all fully vaccinated if they receive the Moderna vaccine. So we are looking for about 33 doses more because we need to complete our second dose vaccine clinic for Reading residents. That's next Friday. There are about 89 participants.
Okay.
Yeah. So yes, with the 200 doses we received this week, we need 33 more doses to complete that clinic. That's why we are contacting with the state for additional vaccines.
Okay, thank you.
Yeah. Any other questions? Okay.
Good.
Thank you so much.
Okay, sure.
Thank you.
Thank you, Shrine.
Carrie, any updates from Incident Command, or was pretty quiet?
It was fairly quiet. We talked about the homebound, which Shrung has covered nicely for us. So I think there's challenges and frustrations with that, and we're wanting to make sure to take care of people. And I'll again give a little shout out to our town because we figured out how to vaccinate some homebound folks before the Johnson & Johnson program was implemented with the federal allocation. And I'm really pleased. I'm glad that we were able to do that because some communities were waiting, and now we'll be waiting a little bit more. So there was some discussion of we're getting now into the place of talking about reimbursements. So there's a lot of work being done, filing applications and documenting what everything has been, what has been purchased and how it has been purchased and who it served. And that's a lot of work. Chief Burns is leading that. So there's new money that'll come in, and there's questions of how do the different pools serve what. So that's taking up a lot of work. We're in a kind of a funny place of kind of moving into recovery, still in the middle of response. We talked a little bit about thinking about what, if everything continues to go well, what will things look like in July? People should start thinking about that. What, do things open more? And what will things look like in the fall? That it's not too early to consider what things maybe, I don't like to use the word normal, but what things maybe definitely can't go back to normal, because we figured out that, like, I use myself as an example. I was assigned before the pandemic to a 3-person office that I never occupied. And it's not big enough for the 3 of us in the standards. So that will never happen. And I'm sure that there are other kinds of circumstances like that everybody all over the Commonwealth is assessing. And so it's time to think, okay, so we maybe are going to be coming back. We're maybe going to be able to open offices more and things like that. And what do we need to rejigger? And just to be ready. So it's planning basically. And planning carefully and knowing that things could change.
Right.
So, yeah.
Okay, great. Thank you.
Yeah.
And Peter, did you have a couple updates?
Yeah, I don't mind trying to wrap up item number 6 here. First by saying that on Tuesday, when we were about to begin with the homebound and the Johnson & Johnson Fire Department, who is the lead agency handling the vaccine, we're responsible for keeping track of it, ordering it, and all that important stuff, was on a call at a country club that was burning down, I guess for the second time in 1 year.
Mm-hmm.
So they were out on an active fire. The news was reporting COVID. The Johnson & Johnson COVID vaccine was no longer useful. And we were pretty much on our heels trying to fight our way through this. And so special recognition belongs to Swung and Christine for following their lead, or taking the lead, I should say, and everyone else followed it, canceling the Tuesday. And then subsequently the following Thursday. So, when we think about things and how to prepare for them, there's so many unknowns that are popping up and about, but I want to give the board the impression that, we really are staffed well. Right? Nobody is, what are we supposed to do? And there's no questions. People are very professional.
Yeah.
And our nurses are just fantastic.
Yeah.
So that was behind the scenes when Shuang was talking about what's happening with the vaccine. I'd like to just say a couple things about recreation and civic events before, too long. I want to try to keep the board up as much as I can on it. Boy Scouts of America, or BSA, they're being called now. Very active in Reading. I think that's great. I'm a big fan of scouting. I think, a lot of leaders came out of scouting. And so the events that are the applications for permits at the town forest are starting to fly in. They're getting a little bit more sophisticated as well. For example, one scout troop is doing an overnighter with tents and serving meals. But and kind of got me on my thinking about that. But the tents, one person tents are with a parent, and so that was resolved. The scout leaders are taking training on how to serve meals probably during this time, and I got the whole handbook on it. So it's
Excellent.
Wow,
really
that's
something,
great.
these guys. So I'm telling you.
Boy
Let's
Scouts
see.
prepared? Shocking.
Yes, that's the motto. Be prepared.
Right.
Let's see. DPW Day is coming up the 1st of May, and I received an application from those folks who want to raise a flag out in front of the main DPW building. Under 150 people, just going to have a light fare, coffee, bagels, and we went through it with DPW. So that has been approved for those guys. There's going to be a bike swap day. I hope I have the dates right, because that one seems like it's on May 1st as well. Can't be everything happening on May 1st. But let's see, our electric division, Power and Light, is going to be hosting this bike swap. It's going to be run by citizens at this location. And boy, oh boy, did they dot every I and cross every T, right down to swapping the bikes between, practice runs before a kid gets to choose which one they want. So I was happy to be part of that, review it, and offer a best towards that event, which I think is a good event. Get the people off the street, more opportunities for different types of transportation. So that's all going swell. With a lot of work put into it, I must say. People are being really thoughtful before they just come to us and say, we want to do this, we want to do that. And the final one is with our senior center, who are extending their bus routes, keeping the same amount of people, no more crowded buses from before, but they're moving away beyond just transporting folks to their medical appointments. They would like to use the buses to take them to get groceries and some other daily functions. I thought that was perfectly swell. And so I said, yeah, go ahead and I'll let the board know. At the same time, and I think we were just talking about how do we reopen Reading slowly but surely and carefully. The senior center director, Bo Miller, approached me and said, what's the best way to go about this? And I feel that, if they have an event that they would like to perform, such as a movie night, if we can do it with the right type of spacing and all that, we can do some of these things and begin to open incrementally. I don't have any direct plans yet, but if it pleases the board, we're just going to move in that direction ever so slowly and get some events going back on the senior center. Don't have to worry about the floodgates opening. It's not going to be okay. We got the congregate meals coming in, and we're going to start everything back, line dancing and all that business. So, the next time we meet, I'll be offering some more updates on what's occurring at the senior center. And that's what I have for the civic events. And I think that should wrap up the COVID-19 items here in number 6.
Great, thank you.
If there are any questions.
Can I just
Sure,
ask one?
sure.
Just Peter, the DPW event, is that a DPW recognition day? Is that?
Yes,
Nice.
it's a historical mark of 100-year anniversary.
Oh, well,
And I don't think it's open to the public. It's just open to staff. They're going to raise a special
Okay.
flag
Okay.
and
Okay.
stuff.
well, I
Sounded
think-
good. And Jane Kinsella, I don't think
Yes.
I've met her yet, but she was really very organized.
yes,
And
She
so
is organized.
very
yeah.
organized. Yep.
Yeah, she's
And-
excellent.
Yep. That's great. I mean, DPW we couldn't do flu clinics without DPW. There's so much you can't do without DPW. So I'm kind of excited that they're getting an event to do
That's
something.
nice. Yeah.
Yeah.
They deserve it.
Yeah.
Especially
carry.
with this year.
Exactly.
Yeah, if I could carry on for just another moment, I was talking to Schwung today. We need friends in DPW. They hold the contract for the shops disposal. So all this infectious waste or medical waste comes through those guys. And, this is the kind of partnerships we want to build more deeply. I mean,
That's
before I
right.
got here, we used to take the shops and carry them ourselves from one location to the other, and they'd be stored in places you couldn't believe. But things are panning out now.
Yep.
And
Yep.
Not to go on a rant, but I'm really excited about the opportunity that's was presented tonight. I mean, when I got here, this was big on the list of to do,
Mhm.
and getting this much closer as the
Yes.
clock is ticking away in the fiscal year is exciting to me. I hope we
Yeah.
can come up with something that pleases everybody. It's going to be a little bit difficult. And I would say, and I'd like to just repeat myself one more time from earlier, that the future of our department here is really as critical as anything else. I mean, you can erase the past as far as I'm concerned. Where do we go
Yeah.
from here?
Yep.
Yep.
Yep. Yeah, well, and having gone through the painful, the creation and the editing and the line by line editing that we did for the procurement for this project, yes, I think we're all very excited. It was a lot of work to get us to this place, and we got a little stuck, and thank you for helping move us forward
Yeah.
more. And yeah, very exciting.
A lot of hard
Very
work.
optimistic.
Yeah. So on that positive note, let me ask about our next meeting. I think it just seems like we might be able to go to the May 20th meeting and not have a May 6th meeting. And my rationale would be, but I'm open to it. I mean, I think we should all hold the time in our calendars just in case. But it seems like the MAPC thing is going to take 2 or 3 weeks to kind of sort through, and that needs to be on the next agenda. I think the health director position should be at that point. We should be hopefully getting candidates. I think that, the COVID stuff at this point seems, from the cadence of the last 3 meetings or so, seems to be pretty stable. And I'm not sure necessarily, I mean, we do need to hear the health division staff monthly report. And that's something that has to be walked through. So one option would be to have our next meeting on May 20th and have Peter sort of report to us in 2 or 3 weeks in an email, sort of what's going on around any of these issues that is available. And certainly, I think that if we hold the May 6th timeframe and think something comes up that we need to have a meeting or, even a focused meeting on 1 or 2 topics or something, we can definitely have it. But I'm not sure some of these other things that we've been following, I don't think they're going to be mature enough to have a substantive conversation maybe for a few weeks.
Mhm.
So how do people feel about that?
I would agree.
Okay,
Seems reasonable to me. Yeah.
okay. Jerry?
Yep, sounds good.
Okay, so let's plan for the 20th. Let's hold May 6th in your calendars. Don't go out to dinner. You should be going out to dinner anyway, but Thursday night. But if something comes up and people feel we need to have it, I'm more than willing. Otherwise, we'll just wait to the 20th. We'll expect Peter, if you can just update us in a couple weeks on any of these issues, it would be useful. And we'll go from there.
Sounds good. Yep.
Right. Motion to adjourn.
Second.
Okay, Paula,
Yes.
Carrie,
Yes.
aye.
Excellent.
All right.
Have a good night, everybody.
Night, everybody.
Great meeting,
Night.
folks. Thank you.
Thank you all.
Take care.
Great work.